Welcome back to the Healthy Chicago podcast, where local health professionals and their guests discuss the latest public health issues affecting Chicagoans. All right, welcome back to another episode of Healthy Chicago podcast. I'm your host, Dr. Bora. I'm super excited for today's conversation. I have my friend and colleague here, Sarah Richardson. Sarah is the program manager in the Office of Substance Use at the Chicago Department of Public Health. Welcome, Sarah.
Thank you. I'm excited to be here.
Yeah, thanks for being here. I know we have a ton to talk about. I know you've been sort of on like a little bit of a media tour, particularly regarding the new vending machines, right?
Yeah.
And so hopefully we'll get to that. But maybe to start, I wanted to just, lay the land a little bit and just talk about harm reduction, what it is, how the Department of Health approaches harm reduction, and any other major pointers about what that means.
Yeah. So I think a lot of people have heard the word harm reduction in the context of drug use, right, and the overdose crisis. But harm reduction is sort of literally exactly what those words mean. It means sort of in a health context, anytime you're doing something risky, which being a human moving through the world is just inherently risky, right? How do you mitigate that risk? How do you reduce the potential harms to just living and moving through the world? So I think it's important to understand harm reduction as something all of us do every single day, from wearing sunscreen, wearing a bike helmet when you bike, right? But within the context of drug use, it has both that connotation, right? How do people who use drugs keep themselves safer from the negative health outcomes associated with using drugs? But it's also a political movement. It's also an advocacy movement that really was driven by people who use drugs and the communities and people who love them in a time in this country, which continues to today, when those communities are severely marginalized, right, and punished for being who they are. And so we sort of think about harm reduction at CDPH as both things like fentanyl test strips, xylazine test strips, Narcan. How do we keep people safe from overdose, keep people safer when they're using, but also how do we support this advocacy movement that is really saying, no, people who use drugs are human. People who use drugs need care and support in our communities. So we think about non-judgmental, non-coercive provision of services. We think about how we engage the community, thinking about low barrier services and health equity in everything that we do.
I mean, that all sounds totally appropriate and totally makes sense. But there is some controversy around this
Totally.
philosophy, I suppose. Talk to me a little bit about that and why we here at the health department take the stance that we do.
Mm-hmm. There's so much controversy, right? And I think, at least if you were born in the United States and sort of socialized, educated here, I can say with fair certainty that you were sort of socialized into a world to understand drugs and drug use in a very sort of black and white, good and bad kind of way, right? People who use drugs are bad. Drugs are bad, right? So therefore, those people need to be punished. Their decisions are moral and bad. And so that has crept into our legal frameworks, right? It's not just that a number of people in this country think that syringe service programs that distribute syringes and take back used syringes and help people use safer are enabling. It is built into our laws, right? Federal funding cannot support syringe service programs. That's just one example, right? So our legal framework is stigmatizing. And there is no basis in public health for a law like that. We know that syringe service programs are incredibly effective at reducing transmission of infectious disease and a whole host of other things, right? And they are a dignified way for people who are using drugs to receive services from people who care for them. And so I think all that to say that it's not a surprise at all when you think that individuals and families and communities have internalized this stigma. It's because we've been taught this stigma. And so it's really about trying to understand what harm reduction is, why it is so effective, and then how you can participate. Because I promise that as soon as you start to be able to participate in it, you get it, right? And it fills you with so much joy, because harm reduction is just love, right? And when you get to love other people, it makes you love yourself, right? And you love your community. So, yeah.
Thanks. Yeah. You mentioned a few really good examples of harm reduction. Some of those, Chicago Department of Health has a foothold in. Mm-hmm. Others are going on in the community. I just want to go over some of those and like specifically talk about how they reduce harm. So I'm going to mention a few that I think you mentioned, and maybe we can talk a little bit about like what are these things doing? Like why are these so important to reduce the potential to harm in people who use drugs? So you mentioned syringe service programs and drug testing, for instance. Maybe we can start there and just start from the basics. Like what do these things do?
Yeah, so syringe service programs are, they sort of sprang up in the United States. It certainly were outside of the U.S. long before they were here, by advocates and people who use drugs themselves, really, especially during the HIV crisis and right before that, when we started to realize, health experts and then people who use drugs, that sharing the equipment that people use to use drugs can actually transmit infectious disease, especially when you are injecting, but not only when you're injecting, right? And so the best way to avoid that transmission is that everybody uses their own equipment and you use new equipment each time you use. And so that's really part of how syringe service programs started. And their whole premise is distributing new supplies, new smoking, snorting, injection supplies, and taking back supplies that have been used so that people don't discard them on the ground, which is dangerous. And it's something that people don't want in their communities, and that's very understandable, right? And so we have a number of those programs operating in the city of Chicago, and they operate on mobile vans. They do street outreach. And the thing is that they don't just sort of distribute supplies and take supplies back, even though that alone is incredibly important. They also do STI testing, right? They do counseling. They often have doctors, you have experience with this, right, on the van who can prescribe medications, who can do wound care, who can meet people where they are. And so I think number one with syringe service programs, with drug checking programs, it's like infectious disease transmission lowers and people are safer from sort of the other negative health morbidities associated with drug use.
Got it. Yeah. What about drug testing? So what does that mean, and how does that help people who are using drugs?
Yeah. So there's a range of sort of tools in this space, and it's an emerging space. Again, started by people who use drugs and advocates who are saying, especially sort of in the end of the 90s and into the early 2000s, we're seeing this overdose crisis really blossom in the country and get really bad. And part of what's going on there is that people are consuming things that they don't actually know what they're consuming, and it's leading to fatal overdose. And so one thing that we can try to do is test those substances to try to understand what is in them, and whether that is before someone has used or after they have used. It will allow them to make more informed decisions. Because right now, one of the key drivers of this fatal overdose crisis is this really quickly changing illicit drug market where people can't understand what they're using fully. And so perhaps they don't think they're using something with fentanyl in it, and then they use something with fentanyl and they have no opioid tolerance and they overdose. But it's also a lot more complicated than just fentanyl. There are so many adulterants in the supply. We can talk about xylazine and others in a minute that may not directly lead to a fatal overdose the way that a drug like fentanyl can or other opioids, but are going to do really, really harsh things to a person's body. So how do we test for those things and then educate folks and work with them to understand what that test result means and how they may or may not change their behavior and engagement with that drug in the future?
Sarah, I keep hearing you, reference advocacy, and what I really appreciate about this harm reduction philosophy is how it excuse me, it brings together, both advocacy, but also like evidence-based practice, right? In a very similar way that it sort of brings together public health with, in some capacity, clinical medicine. At least from my background as a clinician, when we integrate harm reduction practices into a clinical setting, it becomes a really powerful space where we are not just using best evidence practices to treat our patients, but we also get to act as advocates for the patients as well. So I don't know about you, but I really appreciate that this philosophy, this approach to public health and to some degrees medicine. It allows us to celebrate every little step as a success in its own rights. Instead of a step toward some bigger goal necessarily. I don't know if you have thoughts on that. Or I don't know, should we be taking this approach to other parts of medicine or other parts of public health? It's so often talked about within the context of drug use, right? Should we be employing it more broadly?
I mean, I think so. I also think maybe we do often and we don't name it what it is, right? So Chicago Recovery Alliance is one of the first harm reduction organizations in the nation. They operate here in Chicago. One of the first ones to really push for distributing Naloxone back before it was Narcan, the nasal spray version. And back when it wasn't legal really for them to be doing it the way that they were doing, but they did it anyways, right? To save their lives and the people that they loved. And their motto is any positive change, which I think a lot of harm reduction organizations in the country say that. And I think that every day in my own life and in the lives of people I love and care for and the work that we do. I think it's powerful in mental health and primary care, right? Like it's not, we're sort of striving for this end perfect goal. That's quite opposite of what it means to be human, right? It's like, what can we do today for any positive change? And I find that to be really empowering for myself. And I think I would encourage others to think about that too. But I do think that's what public health is,
yes.
Right? That's the sort of the core of who we are, even if we don't say it that way all the time.
Right.
Yeah.
Well, you also mentioned right now Chicago's place within the world of harm reduction. And, the city has a deep history in this sort of advocacy and philosophy. Can you speak a little bit about that?
Yeah. So I think the history really starts with community advocates and organizations like Chicago Recovery Alliance and many others in the city. And it really continues to be led by those advocates, by community organizations, task forces that convene every day. They have folks out overnight and in the morning, really trying to address the crisis. And in some ways, I think the city is like catching up now, right, as government often does. A lot of that comes from, it wasn't until 2021 that we could purchase fentanyl test strips with federal funding, right, to support the community. So a lot of it comes from these sort of higher levels of government and entrenched ways of doing governance that puts us behind, right? And that's okay. I think we're always sort of being pushed by advocates to do better. And I think that's a privilege that we have to work with them. But Chicago is also, especially our west side, really the heart of a lot of the overdose crisis in the country, right? We see our really big cities really heavily impacted. So you hear about Philadelphia and Baltimore and New York City, San Francisco a lot in the news, and Chicago is right up there with all of those cities. And so, we have 3 to 4 people every day die of an overdose in the city. But I think what is at least unique to me, or how I see this, is that I don't hear about Chicago in the same way that you hear about San Francisco or Baltimore or Philadelphia. And I don't quite know why that is. I have some suspicions, but we have more people die every day in the city of overdose than homicide and traffic crashes combined. But we hear a lot about those. And so I think a lot of this is also about the narrative of the city and what parts of the city are affected, which gets back to health equity. Most of our deaths are on the south and west sides of the city. So I think understanding Chicago's place and the magnitude of the crisis here is really important.
Well, let's talk about the crisis a little bit. I mean, what is the state of things right now in Chicago? Are things getting better? Are things getting worse? Are they stable?
Yeah, so there are lots of different measures to try to understand that, right? And so the top line one that we focus on all the time is fatalities, drug overdose deaths. And that is measured through our medical examiner. There's a bit of a delay in that data, but what we've seen since 2019, and this is the same as what we saw in big cities all over the country, is between 2019 and 2021, really steep increases, over a 50% increase in the number of deaths each year of opioid overdose. What we are seeing in 2022, so last year, is a very slight drop in Chicago, in the city of Chicago, in the number of fatal overdoses. And we are cautiously optimistic that that's sort of going to continue to drop just a little bit in 2023. And so I think it's far too early to say that our overdose deaths are dropping significantly or on the decline, but we're not seeing increases like we were seeing a few years ago, which is positive and different from other jurisdictions. But there are other measures, right? So 911 calls for overdose are not really dropping in the same way. And then it's a lot harder to measure the effects of drugs that don't cause sort of an immediate overdose, because you don't always have that interaction with the health system to measure, right? So, people may be using drugs in the community and like xylazine maybe in the drug supply and causing really bad wounds or really really negative sort of interactions with the drug, or a really a traumatic high or experience, and the person may never report it, and so there's sort of that opacity to the dynamic as well that we don't have as good of an understanding of.
Right. How much is, how do we monitor, I guess, the drug supply in Chicago? What do we know about what's out there? Are we able to monitor trends either from other cities or looking at things across our across our own city? I know you mentioned a few substances, including fentanyl and xylazine, both of which have been in the news recently. But how do we keep track of those things?
Yeah, so we are not able to sort of comprehensively, no big city, no place really is, just due to the sort of legal framework that we have put drugs into. But we definitely watch other big cities. So often what we see in Chicago in terms of drug trends will start on the East Coast. So looking especially at Philadelphia, New York City, Baltimore, they have drug checking programs. They have data they can report. So we're always watching that and learning from them. We have a drug checking organization run by CRA in Chicago, and we're looking to fund some others in the city to start being able to test drugs before or after people have used, or the paraphernalia they've used to use with, to try to understand and build like a database of what is in the drug supply. And then also working, we have an exciting opportunity from the CDC to fund a laboratory so that we can do testing on a mass spectrometer, which will allow us to do a much more in-depth testing of both drug supplies and things people use with, but also blood and urine samples from emergency department admissions and sort of inpatient admissions, right, to try to develop a holistic understanding. And then we're starting to, in the very, very early stages of seeing whether we can use wastewater infrastructure to test for things like naloxone. Like, can we understand how much naloxone is being used in the population? And, how does that match against overdose hotspots in the city to see whether we have saturation, whether resources are where they need to be.
Okay. So when you say that, testing in wastewater, you're talking about looking at sort of the sewage system, right? And seeing if we can detect naloxone, this overdose reversal medication in our wastewater, in our sewage water. So that we can locate where that's being used around the city. Is that right?
Yeah, and it's not highly precise. Like wastewater analysis is not highly precise, but it's more trying to get in these catchment areas at a very aggregate level, an understanding of a baseline sort of use of naloxone. Because in Chicago, we distribute a whole lot of naloxone, but we don't have data on often, or really at all, whether those were used to reverse an overdose, right? And so that is this big key missing piece of information a lot of jurisdictions are grappling with. And so we don't know yet whether wastewater will help us answer that question, but we hope that at a big aggregate level it might.
Got it. Yeah. So I think important too to remember that when we're looking at anything in wastewater, we're not looking at specific houses or specific locations where things are from. It's not like we're able to tell who's using drugs, who's using naloxone.
No.
We're just getting an idea of big chunks of the city where we're seeing trends, right?
Right. And trying to establish a baseline understanding of like what is in our wastewater at baseline, so that then if we do see a spike of something or see a dip in naloxone use, we can try to understand why that is, rather than precisely measuring day to day what's going on. Yeah.
And beyond understanding, I think hopefully then we'd be able to deploy some sort of intervention to that location.
Right. Yeah. And I think with naloxone specifically, there are just a range of interventions, and we think about targeted intervention, trying to get naloxone into the hands of people who use drugs, people who will be with them when they use drugs, their families and communities. And then there's sort of more general public distribution, which we do through our libraries and places like that, where anyone in Chicago can go get naloxone. But the question from a public health perspective is that resulting in lives saved? Or like, what is that resulting in, right? And we hope that it's lives saved. We hope that it's naloxone in the hands of people who are willing to step in and reverse an overdose or can be there. But we don't have a full answer to that question. And I think for many reasons, it's important to try to get there. Who
should be carrying naloxone?
People who use drugs, people who are around people who use drugs, families and communities, especially in areas of the city most impacted by drug overdose, people who have recently been in prison, people experiencing homelessness, people who are pregnant or have recently been pregnant. These are groups that are at disproportionate risk of overdose, and it is really imperative that we get this medication into their hands. In Illinois and in Chicago, we are really privileged to have a lot of access to naloxone. And so, we make it available in every library, in our mental health and STI clinics and all over the city. So anyone can carry it. Mm-hmm. And with the level of the crisis that we are in right now, I would say that if you feel comfortable and willing to carry naloxone, it's important for you to be able to do that. And so you can go to your library and get naloxone. It won't hurt the person you use it on if they're not experiencing an overdose, which I think is important. But really, who should be carrying it is people most at risk of overdose.
Got it. Yeah. I always have one in my bike bag. Mm-hmm. I've encouraged family members to carry it around. And like you said, it's fairly easy to use. You know, I am, fortunately, I haven't had to use it outside of the hospital setting. But you never know. You never know when you will come across someone who's experiencing an overdose, and it's good to be prepared. Mm-hmm. If someone wants to carry it, but they don't know how to use it, are there resources where they can learn, how it works and how to use it?
Yeah. So the first great thing is that even before this, but this summer, it went over the counter. So anyone can go to a pharmacy and pay about $45 to $50 if you have that, or if your insurance will cover it, you can go to the pharmacy, part of the pharmacy, and get it. You can also go into any library, and the FDA changed the box. So it's a taller box now, and on the back of the box, it has instructions for how to use, and it is very much just a nasal spray. Mm-hmm. So at minimum, you have that box no matter where you got it from, and you can kind of read those instructions. We also make information available on how to use it and how to recognize the signs of an overdose. We do a monthly public harm reduction training. We use our social media to try to inform people about the signs of overdose. It's also, you can Google it if you have access to the internet. It's a really common intervention. A lot of public health departments are talking about it and creating content to make sure you understand how to recognize an overdose and how to respond.
Mm-hmm. Like you said, it's over the counter now. So access has become, it's become widely more available than it had been previously. But I really appreciate Chicago and the Department of Health pushing it into libraries, really just normalizing it, being out in the community. I will say, as someone in public health, I've been in other states where even those ideas are difficult to get across the starting line, to have Narcan so widely available. So I think it's such a great effort by our city. So can you tell us a little bit more about what other projects are we working on? I know one of the big ones recently has been this vending machine project. So maybe you can mention that. But anything else that we're working on or thinking about?
Mm-hmm. Yeah, so vending machines launched in early November. We have 5 of them run by the health department around the city. And they have, they're vending machines like you would buy soda pop from, except inside of them we have Narcan, fentanyl and xylazine test strips, general hygiene kits, tampons, pads, socks, underwear, things that people may need for a variety of reasons, and they're all no cost. So anyone of any age, there's no restrictions on who can access the products. You can go up to the machines and type in a PIN code and get what you need, and there's no restrictions on how much you can take as well. So we have five of them. There's 2 on the south side, one on 115th Street at the Roseland Triage Center, and one at the 95th Red Line CTA stop outside of the turnstiles. We have one downtown at Harold Washington Library, one on the north side at Uptown Library, and then the 5th one is on the west side at the 10 South Kedzie Community Service Center. And we've been operating them, it's been a month and a half, almost 2 months, and it's been really successful.
Do we have early data?
Yeah. So we have had almost 150 Narcan kits vended out of all of the machines, of collectively. And then we ask people to sign up for a PIN code, and so we're able to collect their zip code if they a zip code, and then some other optional information if they choose to tell us that. And so we have had, I think it's 350 different PIN codes activated. of the people who answer those optional questions, almost 50% report having witnessed an overdose, and about 16% have reported themselves overdosing.
Wow.
We have a lot of other demographic and age and treatment history information we're still working through. But yeah, we're seeing general hygiene kits and socks and underwear as the most popular products. The CTA machine is the one that's been 24/7 fully. And we're seeing people vend things at 3 a.m., at 5 a.m. And to my knowledge, there are very few, if any, places in the city where you can go for free and get Narcan at 3 a.m. And we know it's one spot and it's, not convenient for a lot of people, but it's a first step in trying to understand that access.
Amazing. Yeah. It's such a cool project. I'm really excited to see, how successful it is and see what data we can collect and then hopefully expand it in the future.
Right.
So you'll have to keep us updated.
Yeah,
and maybe join us again. I think as we wrap up, I just wanted to make sure, if there are folks out there who themselves are struggling with substance use or have a loved one, what resources does the city of Chicago have to reach out to?
Yeah, if you're struggling, you're not alone. So there are just a lot of resources. If you just you want to talk to someone about drug use or make sure that you're using in the safest way possible, there are a lot of harm reduction organizations in the city that can support you, like Chicago Recovery Alliance and many others. And you can reach out to osu.cdph@cityofchicago.org if you want to talk to our team about where you can engage with that, or sort of go to those organizations in person. If you're looking for treatment, or you even just want to have a conversation about treatment for opioids because maybe that's new to you or you're not sure what's available, you can call a 24/7, 365 hotline that operates in the whole state of Illinois. Now I'm forgetting it off the top of my head. 833-234-6343. That's the Illinois helpline for opioids and other substances. And if you ask for opioid treatment, they will immediately connect you to our MAR-Now program. And that has a doctor on the line and a care manager on the line. And they can actually prescribe you buprenorphine, Suboxone, for starting at home. You don't even have to go into the clinic if that's something that you want. Or they can make an appointment in clinic or in a methadone clinic for you. We can connect you to residential. But it's really like a one-stop shop for opioid treatment. And even if you don't want medication, they'll talk to you about other options. And they'll talk to you about what it feels like to start medication. And if you're a family member, you can also call that number. And care coordinators will kind of help you understand how to help your loved one.
What's that number one more time?
833-234-6343.
Awesome. Yeah. We've actually, so I work in a clinic on the west side of Chicago with UIC. And we've rolled that MAR-Now program, that phone number, into our workflow, for folks who maybe can't make an appointment that day or new folks who are eager to get in the clinic, but again, can't make that day and want to see us later. And it's been successful. So some great programs, some really powerful resources that we have. Not only across the city, but it sounds like across the whole state.
Yeah, and I will just say, I think a lot of people hear about treatment and they say, well, nothing's available, and, this is just another resource and it's hard to access. 99% of people who call that line looking for Suboxone are connected to Suboxone. 75% who call looking for methadone are connected, and that gap is just because you got to go in person to your first methadone appointment, and some people don't show up, right? But we provide transportation. We will send a car to your house to pick you up anywhere in the state of Illinois and take you to the clinic or pharmacy. We will serve you if you have no insurance, if you cannot pay, right? So this is like as low barrier as possible, and you will get care if you call that number.
Awesome. Sarah, I have so many more things to ask you about, but I think we're out of time. Thanks so much for being here with us. I hope you can join us again soon.
Yeah, thank you.
All right, thanks. Thanks, guys. We'll talk soon. And that's our show. Thanks for joining us today. Don't forget to rate and subscribe wherever you find podcasts. I'm Dr. Bora, and we'll see you next time.